I'm Ray Sterner, and I'm Director of the Center for Promotion of Child Development Through Primary Care and on the faculty at Hopkins. And Barbara Howard is likewise faculty at Developmental Behavioral Pediatrician. You want to say hello, Barb?
Hey, welcome everybody. We've got a lot of interest in this topic. So
right. Anybody recognize this picture here from the last 2 weeks? Anybody get Time Magazine? If you did, this was, I think it was a week and a half ago. It's really in our face that anxiety, depression, and the American adolescent is something that everyone is talking about and concerned about, and I'm glad you're here because we're going to be talking about some ways to address this problem. We're going to focus on, and at Chattis, we worked with a group called the GLAD PC. That's Guidelines in Adolescent Depression in Primary Care. And it came out in 2011, actually. There was a large expert panel led by some people in Columbia, but it was a very extensive adolescent doctors and child psychiatrists, and they came up with a white paper. This followed actually after the black box warning on antidepressants and the concern, what, if anything, should we as a primary care doctor do when facing addressing the issue of depression. And so we'll be talking about, and where I depart from, there won't be much from what they say. I'll point that out. So that if you've read the Time Magazine article, they talk about, we've been thinking about depression, been concerned about it, but like an epidemic. So is this sort of like the autism one? Is it because we're starting to look more, or is this real? And I think there's evidence that it's really increasing. And there's one episode of major depressive disorder in the past year. We're talking about 3 million teens in the United States. And it turns out to be more prevalent in females, like 1 out of 5 females at this age, the adolescent age group, and 5.8 of males, 5.8%. So why is that? Maybe you all have an idea. I'm thinking that it is real, that there is an increase, and that methodology would suggest that it's not just diagnosing. And so some people in the magazine suggested, this is post 9/11 era of economic and national insecurity and election insecurity, you could say, for some. But then there's some, and you'll all have your ideas, and there's no real definitive study here, but one that I think we can't overlook, and that is what has happened in the last 10 years we're talking about, since 2006. And it's the access, the 24/7 access to the Internet for all teenagers, essentially, by their smartphones in particular. And I think that if you think back in 2006, the Internet was there. But if you think back in your practice, and your own kids, it just wasn't that total involvement. And the idea basically is that kids get stressed out. They're teens. They're dealing with problems of identity. How do they fit in? How can they be a big shot? And then they go home, and they can, it was a kind of sanctuary, perhaps. They could watch TV and be amused. But now they go home, and unbeknownst usually to their parents, they are continuing this struggle for identity and fitting in on their phone. And so one of the kids said this wasn't the kid, this was the conclusion of a social media study of 13-year-olds. And the conclusion was There's no firm line between their real and online worlds. And then in the Time magazine article, I thought the teen said it quite well. She said, "We're the first generation that cannot escape our problems at all. They go to bed with that smartphone and tweets and the Facebook. Are they getting likes or dislikes? And hearing about things that they may be in a rural community, and maybe somebody has had suicidal ideas, and they're in Los Angeles. They're communicating with them, and the whole idea that some of these angst and lack thinking has a contagion. Well, it's that may be there. So that's a speculation. But then to put it in context, the pediatric context of the trajectory of mental health problems, when we're talking about 6-year-olds, they are anxious. 4 and 5-year-olds are worried about spiders and all kinds of things, and gradually it sort of peaks then. And then the behavior issues seem to peak at about 11 years old. Oppositional, defiant kinds of things are emerging. Then mood issues are emerging. The median age of onset is 13 years, a little later. And then there's substance use by peaking at 15 years now. So, but in thinking about this trajectory and the prevalence by age, we do know that anxiety disorders sort of bleed into mood. There may be precursors, and angry behavioral kinds of manifestations can evolve into depression also. So that the prevalence of severe, if you look at all of childhood, severe mental health disorders with impairment, mood's number one. So, and then there is some data I just threw in here in sort of looking at maybe kids they're always there. Anxiety is pretty common. If you're anxious, and we're trying to work out cause and effect, but in some longitudinal studies, bully victimization and cyberbully victimization differentially even predicted depressive symptoms and trajectories across adolescence. So that's some support to, and I'm just not going to dwell on the internet stuff, but I'll add, and you'll see that I do believe that, while I don't know what the cause of the epidemic is, that if you're going to be talking to adolescents, you're going to need to be able to be conversing with them about their social media experiences. And that's something we're going to add to the LAN PC recommendations. So no one can argue a big priority NIH is suicide, teen suicide. It's now, since 2010, it's the second leading cause of death, non accident. 5,500 teens killed themselves in 2014. There were over 2 million attempts, and 90% of the time the parents were not on to this level of problem behavior in their kid. And then the thing for us to know is that the majority of individuals who die by suicide, this has been a fact known for some time, had contact with a health provider within 3 months prior to their death. And those if you look back, and what were those contacts about? They were presenting with somatic complaints, and they infrequently discussed their suicide thoughts and plans unless they were asked directly. So certainly, now I want to also say that not all suicide is related to depression. I'll just say that, because it's another topic. We don't want to say it's exactly about depression, but certainly depression is a extremely important precursor. So otherwise, certainly we want to prevent death as doctors. and we're identifying under-treating them in primary care. But also, apart from the most serious outcomes, it interferes with concentration and loss of pleasure in the kids we're seeing, and they are more tired than they needed to be. That may be affecting their school attendance and certainly their academic functioning. They may show up as just being irritable rather than being sad, short-tempered, hard to please. And all this confabulates what you're hearing from the family, because it's a chicken-egg thing. Because that kid's got a attitude, right? And is it from the depression? Is it from the overly critical family? Hard to sort out sometimes. And then there are the feelings of worthlessness that can undercut their self-confidence, and that can affect their schoolwork, their involvement in things outside of school, and their overall self-esteem. Then there are aches and pains, and for which they come in and you really don't find anything. So, what are the recommendations for primary care coming from the august GLAD PC committee and the AAP? First, most importantly, ask directly about depression and suicide. You cannot rely on teens to voluntarily bring this stuff up. Second, the recommendation is to screen yearly for all teens, and you combine depression-specific tools with a follow-up interview and include parents. And then you've got interview data and you've got the screen data, and you're trying to figure out between the two what's a real diagnosis, and really how impaired is this kid? How serious is the problem? Is it really depression? And so there are some fairly obvious. Any kid with emotional problems who's a teen, you better be thinking about is there some depression going on? And the ones with frequent somatic complaints, certainly. And then there's some fairly obvious depression risk factors that get your attention: previous history of or family history of depression, bipolar, suicide or suicidal-related behaviors, substance use, significant psychosocial stressors, family crises, physical, sexual abuse, neglect, other trauma, and history of previous episodes. So what I'm showing you here is an algorithm. This is one view of the identification process recommended by the GLAD PC. And we're going to break this down. So what they're saying is, if there's a kid with an emotional issue as a teen, you better assess them. We're going to talk about what that means for depression. But for every checkup visit, you screen. And if they're positive, then you do an assessment. An assessment involves using a diagnostic tool. It involves interviewing the teen and the parent separately and together, and assessing for safety and suicide risk. And then when you do that, there are kids who are suicidal or psychotic. They need crisis services, emergency services. They need to go to the ED. You need immediate consultation, obviously. Then there are kids who are depressed, but they're not psychotic or suicidal. And then the clinical challenge is to say, how severe is it? And we're going to talk about that. So what your plan will be based on your estimate of severity. Certainly the first thing you're going to do, though, is to evaluate safety. Then you're going to do some family education, and then we'll talk more about some of the pathways that you'll take based on the severity of the child. If a child doesn't, you do your assessment, they screen positive for depression. They don't have depression by diagnostic tools. Maybe they have some other mental health comorbid conditions. So you'll need to, of course, address those. There are other guidelines that we're not going to get into for those. But there was something about them that made them positive on the screen. The screen's not diagnostic, but we're going to have to monitor them more closely. So what are the screening tools that the GLAD PC committee recommended? There's three. The PHQ-9 is the most widely known. You have the 9 items, and guess where they're not going to have less than 9 items because there are 9 symptoms related to make the diagnosis of depression. And you have to get 5 out of 9. That's part of and then you have to have impact. It's sort of like the ADHD. There was 6 out of 9, if you recall. But then there's some items that got combined actually in the Kuchar depression scale. The brief scale, they recommended that one. They recommend the Columbia Depression Screen at 22 items. There are other tools. The one that the CDC developed, 20 items. And then there's the Beck Depression Scale, 21 items. I noted the ones that are available in Chattis, with the asterisks there. The Beck and the Columbia Depression are ones that are proprietary. And now this is where I depart a bit from the GLAD PC or elaborate, because we've been thinking that when you're screening for depression and you're going to have that conversation, you're going to have any conversation with teens, you need to have a problematic and risky internet use scale, PRIUSS. So we put together a bundle of tools, and we did this because we were interested in having a suicide screen, and one of our users suggested that you don't want the teen to see something just, that has the word suicide all over it, that you want to be a little more subtle. So we put together a package. There's the PHQ-9, there's the internet screen, the CRAFT for substance abuse, that's a very brief screen, and the ASQ for suicide, which I'm going to show you, that has 5 questions in it. We want that whole package. And now let me just tell you a moment about the problem and risky internet use scale. There are 2 scales. The original one was 18 items. Dr. Megan Marino in Seattle developed this, is well standardized. She came up with a pre-screen, a 3-item screen, and if you're positive on the 3 item, then you take the remaining 15. It's what we did in Chattis is we put those 2 together. So immediately, if you fail the 3, you will be given the 15 other items. You don't have to wait for another visit to do that. It will be chained to the initial pre-screen. So that's a package that we recommend. And let me just say this: this is one that we're reserving for the use in the waiting room only, and that's because this ASQ suicide screen developed by the Hurwitz at NIMH and her group. They feel that you shouldn't administer that screen when there's some place, at home or some place where they're not in close proximity to a clinician. So we wanted to reserve that just for the waiting room. We have other strategies for when you're doing it from home. So just a deeper dive, the PHQ-9, I'm not particularly advertising PHQ-9, but it's one to pause about because it is actually the definition of major depressive disorder. Over the last 2 weeks is what it is requiring, and how frequent. More than half the days, nearly every day. And then there are the 9 symptoms, and these are the 9 symptoms that come out of the DSM. A little interest and pleasure in doing things, feeling down, trouble with sleep, little energy, poor appetite or overeating, feeling bad about yourself, trouble concentrating, moving or speaking slowly, or being overly fidgety, and thoughts that you'd be better off dead. And then there's the item that asks about impact. You may have these symptoms, but is it really getting in the way of your daily life? And so that's worth looking at just to review what we're talking about. That's the definition of major depressive disorder. So I said if they screen positive, you should do an assessment. Well, there are diagnostic tools. One is the PHQ-A, and that covers depression, anxiety, and substance use. In Chattis, we have, and we're just finishing a revalidation of this tool, but validating for the first time with the DSM-5 criteria. This is a tool that where the parent goes over a wide range of symptoms, it says how frequent they are, then how concerned they are, and then they prioritize which cluster of symptoms are they most concerned about, and then they'll go through the algorithm of the logic of the DSM-5 and DSM-PC, because the Academy of Pediatrics has designated that pediatricians should weigh in on cases that are not just disorder but problem or variation, less levels of severity, so as to pick up on subthreshold cases. CBCL, Child Behavior Checklist, those things are available in Chattis. The BASC, B-A-S-C, is a very good comprehensive tool. We do not have that available as of yet. And then an interview, and you have to establish confidentiality. You know the limits are. If there's a threat to your life, I'm going to break confidentiality. You need to realize that you may not recognize their depressed mood. They may cover it up. And you're going to have to distinguish transient depressive responses that are situational from a depressive disorder, and be thinking about these common presenting symptoms, the ones I read off from the PHQ-9, but also as they show up in family conflict. And then you're going to talk to the other caregivers separately and ask about how the symptoms are showing up in the household and functional impairment, and the family relationships that may impact on how this is presented, whether who's angry at who. And then also keeping in mind that some cultures they're not going to be as willing to talk about some of these symptoms. So this is the process. The child screen positive. We're going to try to decide how you say they've done the evaluation, they're depressed. They meet criteria for depression. Now, the diagnostic challenge is to say how severe. So there's mild, these 9 symptoms, okay? You get 5 or 6, you could be mild if there's not much impairment. That is, it's not getting in the way of their normal functioning, or they can even be normal with, they put a lot of effort to put out a good face. And then severe, where most of the symptoms, and the symptoms are severe, and it's obvious that there's a disability. That's severe. In between is moderate, okay? And there are some caveats. That is, you could be mild, but if you've got mild by these categories, but if you've got a suicide plan or psychotic symptoms, you jump right to the severe. There's a caveat about if you have first-degree relatives with bipolar disorder. That's just in there. I'm not sure what to think about that completely. So you have to pause to do a differential diagnosis. You know that chronic illnesses can also have fatigue, alter sleep and appetite, and depression is more common in chronic illness. So you need to do an examination. Think of substance use that can confound the picture. And then there are these rare drug side effects kinds of things, phenobarbital, antihypertensives, steroids. Accutane can cause depression, and it has a black box warning for suicidal thinking even, and over-the-counter drugs containing synthetic narcotics. So you also have to think about comorbidities. It may not just be depression. It may be this. They've renamed dysthymia, now called persistent depressive disorder, DSM-5. But these are people that it's not like depressive disorder, they've sort of always been that way. At least for over a year, they've been down. And then they could have, you could be looking at an adjustment with depressed mood, and if it's less than 3 months, you'd call it that, and especially if there's an obvious stress. And then other psychiatric disorders, ADHD, learning disabilities, anxiety, eating disorders, and substance, they all co-occur with maybe depressive disorder. So the GLAD PC, it goes on, and I've tried to break down their algorithm. Ask the initial management. So you've decided that this individual is depressed, and you've decided how severe it is. So if they're mild, the GLAD PC has said, well, the primary care doctor can take care of it themselves. You watch, and there's this magical 6 to 8 weeks, and you can just monitor them, and we'll talk about other things you might do. But essentially, you monitor if they're improved, fine. If it persists, then you go thinking about them as you would if they were moderate. If they're moderate or severe, it's always that they're severe, you should get a consult. Now, when we're talking about, so many, 1 out of 20 kids almost we're just not, there are not enough child psychiatrists around. But we should use them well and get a consult, and you can manage getting a plan. And then in the plan and negotiating with the child psychiatrist, you decide who's going to do what and how you're going to work together and communicate. And this integrative mental health primary care arena is a really important one. And I'll just mention in Chattis, we're working hard to develop actual electronic platform to allow you to pass information and track the pathway of the child. But I won't get into that now. We've just been funded for that. We don't have it. It hasn't materialized yet. So we're going to decide are we going to refer, we're going to manage in primary care. And some of the moderates we might manage in primary care. And what we're going to think about are evidence-based psychotherapies for referral or evidence-based medications. We're going to monitor for symptoms, adverse events like suicidal ideation and mania, and we're going to consider consultation. And when we think about the role of in primary care, we're going to think about what we can do in terms of psychoeducation, supportive counseling, and I'm going to give you some suggestions along those lines. So there is this period of 6 to 8 weeks. It coincides with pretty much when you'd expect medication to kick in, but this is sort of the trial period notion. And the idea here is if this is a mild case and primary care is taking over, it's not just watchful waiting, but there are some specific things that you can do. And you schedule frequent visits, weekly visits, and you prescribe regular exercise and leisure activities, recommend a peer support group, review self-management goals, and follow up with it by telephone if need be. And you provide educational materials. And I'm going to give you some more resources that we have developed along with the GLAD PC that will make that a little more real. I'll show you in a minute. So we're going to provide education, and if there's no improvement after that period of time, we're going to be more specific. And then more severe ones, as we've discussed, if we need a mental health consultation or crisis intervention, we'll be on the alert for that. And we're going to continue the management strategy. First, we made a decision, are they depressed or not? How severe are they depressed? That will dictate what we do. Now, we tried for 6 to 8 weeks. Did they get any better? Did they improve? If they improve, will say if they were on medications, we will still continue them. And the recommendations are 6 months to a year, and actually monthly monitoring, and even continuing to monitor after they're off the medication, and maintaining contact with the mental health provider if they've been involved. If they're partially improved or not improved, we're going to first, if they're not improved, we're going to reassess, is this the right diagnosis? We're going to consider adding medication if we didn't already, or increasing the dose to the maximum tolerated, or changing medication, and adding, if we haven't already, a psychotherapy, and making our mental health consultation. And further education, we're always going to be thinking about reviewing the safety plan. So our first priority in all this work is keeping them safe. They're certainly at risk for suicide, and particularly at the beginning. And we need to ask, and teens, we always say they are shy about talking to us about, they want to impress us about these bad things. They're much more likely to confess to a computer. So we're going to use a computerized screen, and I'm going to show you what that looks like.
Ray, can I just to have a little bit of a conversation about reaching for meds and how to think about meds. I think for many teenagers and families, when they stay on meds for a year, that's a lot of times people don't like that or want to do that. And so I want to just offer kind of how I think about that with families, because I think that can be very off-putting. Unfortunately, it can be very off-putting and can feel like we've lost them before we've even gotten started. I think that it's really important when we're doing any kind of informed consent to think with families and patients about the risks of using the medicine and the risks of not using the medicine, and what data we know about what it's like for a teenager to live with depression that's untreated in terms of the academic risk, the social risk, things like that. And I think that becomes an important part of the conversation. The other thing that I always talk with families about is that when we start a medicine, we are not starting the medicine for a year. We are starting the medicine as a trial to see if it works or not. If the medicine works, then there's a new decision point that happens, which is, does the teenager and family want to continue the medicine? But I think it's really important to break down this idea of starting a medicine, staying on it for a year, into its multiple parts, because there are multiple decision points along the way. There are families who they acknowledge that the youngster got better on the medicine, but they still don't want to keep the kid on the medicine, or the kid doesn't want to take the medicine anymore. And we don't keep somebody on medicine if they don't get better on it. So that kind of conversation just makes it, I think it's a much easier conversation than to lay out, we're going to start a medicine and you'll need to be on it.
This is the ASQ for suicide. Ask suicide questions. These are the questions. And it's available in Chattis, and you could ask it yourself, or they could do it on the computer, and you can see them, and then there's some more details about it if they say yes. Have you ever tried it? It's pretty straightforward. This has recently been validated in emergency rooms and in pediatric hospitals. So, yes, we need to begin the conversation. I was giving an overview, and Emily's exactly right. We need to destigmatize this. We need to educate the parent, first of all, about what this is. It probably comes from an innate predisposition made worse with recent stressors. That what's depression about? It's liable to recur. Without treatment, it may last longer and recur more, and it requires ongoing monitoring, and there are options for treatment. We need to get buy-in. We need to educate. These are some handouts that are available through Chattis. This is a NAMI handout for the family in terms of education. This is the NIH handout that's available in Chattis for the teens. So we come up with we try to get to a specific treatment plan, and have goals, and we're talking about some things that seem namby-pamby: regular exercise routine, adequate nutrition, meetings to resolve issues at home. These are some things that pediatricians can do. This is a really nice handout that is a worksheet that you could use to actually do these things. This is available in Chattis as self-care. And what you're doing here is you're reviewing these things and saying specifically, pick a date and time, make it reasonable, think about all of these things, spending time with people who can support you, spending time relaxing. These are goals. You're doing a motivational kind of discussion with them. Which ones are you willing to do? What can you commit to? And we're going to be talking to you more about that. This is a very nonspecific kind of engagement that one might do. One might talk to them about sleep problems. This is some things that it can be done in primary care. Making a referral is a clinical challenge. It's not like go see the cardiologist. They have some mixed feelings about needing self-consciousness about whether they really need it and attitudes. And so it's a matter of a real clinical challenge to make a referral and understand, are there barriers, insurance barriers, and listening to the preferences? As Emily says, some people prefer medication, some people don't. We need to engage them in the discussion of all the modalities that are have evidence and may be helpful and not oversell any one of them. And we have to have a plan for communicating between mental health and primary care. So we need to determine if there's agreement for a consultation. There are some release forms, and there's something we could do in Chattis to communicate back and forth. There's something called problem-solving treatments for primary care that have some efficacy as a trial for the first 6 to 10 weeks. That requires the primary care doctor to have gotten some training in these problem-solving counseling. There are 6 30-minute sessions. They essentially about solution-based. It's called identifying, clarifying problems, setting realistic goals, generating solutions, evaluating progress. And then there's evidence-based psychotherapy, and this is no side effects for this, really. And there's evidence for teens. About half of them respond. It's not like a perfect bullet. And there are individual therapies and they're group therapies. They're usually an hour long, and we're talking about 8 to 20 weeks. If they're not improving after 6 to 12 weeks, that's when we add medications. Think again about adding medications. And if they're really severe, the general guideline, this is the guidelines from the GLAD PC, is that it shouldn't be the only intervention. What are these psychological therapies? They're CBT. The idea behind it is that there are thoughts that influence behaviors and feelings and vice versa, and pessimism, being down on yourself, not seeing, interpreting things in a pessimistic way can lead to depression and sustain it. So the essential elements in CBT is behavioral activation, increasing pleasurable activities, cognitive restructuring is what they talk about, reducing negative thoughts, and improving assertiveness and problem-solving skills to reduce feelings of hopelessness. And then there's evidence for interpersonal therapy. And these are therapies that have evidence based on a manualized. People were reliable and they did what was in the manual. In this case, we're talking about the notion that interpersonal problems cause or exacerbate depression and vice versa. And it's identifying the problem, working on problem-solving skills, and modifying communication style. There are handouts in Chattis that might go along with a referral for therapy and thinking about some of these issues. And then now I just wanted to talk a little bit about pharmacotherapy. as an option and something that, as Emily says, you discussed. There's some parents who prefer it, and it's not a first line, except if it's severe, and that there would be first line then. But the first 6 to 8 weeks, if there's no improvement with a non-medication, then the GLAD PC people would say then you should be thinking about medication and introduce that. So 25% of U.S. Pediatric primary care doctors have used an SSRI, and more so in family medicine. We, as Emily said, you need to certainly tell them about the black box warning and safety, including the issue of suicidal thoughts occurring, especially early on in the use of SSRIs. They need to talk about the common side effects, the importance of having the medication be administered and supervised initially by an adult if possible, and that the likely duration. We're going to be talking about reevaluating all along the way, but the likelihood is that we want to continue it for some time. And there are problems and symptoms from withdrawal. So fluoxetine is the first-line treatment that is FDA approved, and this is the one that GLAD PC recommends as a long half-life. There are others that are now considered first line, but this is the one that you can feel that there's most of the establishment behind you. And you are going to be watching out for agitation, irritability, and then having to adjust the dosage as needed. So there are other SSRIs, but the first line would probably be, and there is a table. Now, all of what I'm showing you, we have a chapter that we wrote in conjunction with the GLAD PC people. It's in Chattis. This table's in Chattis. I won't belabor it, just to show you that there are some guides for dosage.
And the slides, this whole recording will be up on the Chattis website under Learn More, if you want to refer to any of the materials also.
So what about this adverse, the black box warning? And I'll just read it. All pediatric patients being treated with antidepressants for any indication should observe closely for clinical worsening, suicidality, unusual changes of behavior, especially during the initial few months of the course of the drug, or at times of those changes, increases or decreases. And so I highlight here the recommendation from the FDA, at least weekly face-to-face contact with patients or their parents, then at least in the first 12 weeks. And the expert opinion suggests telephone contacts may be as effective as face-to-face, but GLAD PC is saying you should probably actually see them. So we're talking about having some goals, assessing how they're doing outside the clinic and school settings and home, and 1 week visit after the start of medications, and always asking about their depressive symptoms, risk of suicide, adverse effects, adherence, and finding the optimal dose. And what is the optimal dose? It's the one that the benefits outweigh the side effects. And weekly follow-up, assessing response to medication, changes in side effects and impairment is what we're watching for. The dose is adequate when we're doing the PHQ-9, repeating it. We're looking for target symptoms to recede, and we would monitor that over time and watch for side effects. And then after 4 to 6 weeks, if there's no change, but they're not getting side effects, you could increase the dose. Here's a handout to help the team engage in knowing if their treatment for depression is working. Side effects, there are many. The disinhibition, increased impulsivity was something to think about, agitation, as well as the real serious ones, the serotonin syndrome of fever, hyperthermia, restless, confusion, pretty rare, akathisia, hypomania behavior. and discontinuation syndrome.
Ray, can I make a comment? Sometimes we see youngsters who have been depressed or anxious and depressed for a very long time, and when they get on medication, there's a little bit of a, woohoo, I'm not depressed anymore, which is not a side effect. It is not an adverse effect. However, sometimes it's a lot harder to parent a youngster who is not depressed and anxious anymore. And so sometimes families need a little bit of support around this youngster is rejoining the world and now will need different kind of parenting than the youngster who never leaves their room. So sometimes what families may see as a side effect is really just the youngster returning to a more normative teenage experience, and that's an important distinction to make.
Nice. That's actually really very helpful. And it's not the same thing as activation syndrome.
No. It's sometimes you'll see it called celebration.
Celebration.
But particularly for kids who've had a lot of anxiety and haven't taken any risks, haven't done anything, or maybe haven't, gotten into trouble with their peers, suddenly they have the energy and they're willing to do some things, and some parents have trouble with that. No parent will say, "Gee, I wish my kid were still depressed," but sometimes they see they don't like what they think the medicine is doing.
That's a great point. Yeah, well, we're talking about, the medications help. They can be a bit dramatic, but we're talking about, 5 or 10 points of score over placebo. So they're worth doing. It may take time, but you may get to celebrate with them. And the general guidance is, if you can, once they improve, to keep them on it for a period of time to avoid recurrence, essentially. And to taper slowly. Fluoxetine you can get away with without tapering too much. And continue to monitor after they're off medication. And they glad to see people say for 2 years, their life as the pediatrician. I had this slide at the end that I started out by saying that computer and internet's the problem. It could be part of the solution also. The jury's out for that, but there are some CPT models that you'll see that are internet-based. They look like they have some benefit. There's actually, the data is they have poor adherence. There are other things. It was a really interesting study from the emergency room where they text the kids, and based on their mood, they got a response, some kind of encouraging response. It's clear that's the way the teens are living. They being able to reach them in the moment might be useful, but not any replacement to an empathic human being. So let's hear from other people.
Questions or comments? Go ahead.
Yeah. How do you deal with now? Most of these are concerns individual patients. What do you do when there's a group of them performing like risk cutting? It's a lot of peer pressure. If you deal with the individual alone, you're not really dealing with the whole problem. More of a school thing. I had a patient who did that. And, it's like daring each other, why don't you do this, why don't you do that? So several of them were cutting their wrists. And, I'm just wondering, there is confidentiality issue, but at the same time, you have to deal with the group per se, and not just the patient alone. How do you advise primary care doctors do that?
Well, that's a really good point. That there is a contagion, and they hear about this online and even in subgroups. That one of the things we said is that part of the therapy is peer group therapy. That may be a different group than they're already in. Mm-hmm. It may be an activity where their peer influences are different.
So maybe get out of that group.
Yeah, to sort of being able to think about that group as differently. And anybody else? Emily, you want to comment on that? I bet you've seen that.
I think that cutting and other self-injurious behaviors are often quite separate from depressive symptoms. And although they may be there in combination with depressive symptoms, but they really are not a core part of a depressive illness typically. They have their own life and often, unfortunately, as you note, are connected to peer activities. And even if they start as a peer activity, they can then develop a life of their own and continue as a solitary activity. Most of the people that self-harm talk about it not as because they want to die, hurt themselves, or they're so sad, but for sort of two similar reasons. One is they feel numb, and so they cut or harm themselves to feel something. The other is that their affective state is so overwhelming that they create physical pain to distract from the emotional pain. And really those are the flip side of the same coin, I would say, for a lot of people. I think that there is a good literature about dialectical behavior therapy, which really to use in young people and young adults that are self-harming. And really which is a variation of cognitive behavioral therapy, but part of what it focuses on that makes it distinctly different is this concept of distress tolerance. Many of the people that cut and self-harm in other ways cannot tolerate the strong emotions that they may be feeling, and they don't have good emotional regulation, so they turn to things to try to block out the strong emotion, distract themselves from it, or pull other people's attention in some other way. And so dialectical behavior therapy, really the basic first task is distress tolerance. The second set of tasks have to do with creating a behavioral chain analysis, which is basically asking people to recreate what happened, what led up to, and to my self-harming, and then what did I do about it, and how did I feel. And they really have to keep a journal of some sort. True dialectical behavior therapy can be delivered individually, but it is extremely powerful when delivered in a group. And so there are groups in many communities where clinicians are offering dialectical behavior therapy for teens in a group setting. And it often is at least twice a week. And it's a pretty intensive experience, but those therapists are typically highly skilled. They're on call for the kids involved, but parents have to kind of sign up for the whole kit and caboodle. So there are really powerful interventions. The challenge is whether the teenager and the family are ready to do them. But I think it's an important thing for primary care folks to know exists out there, because there are interventions that are separate from more traditional interventions for depression. Some kids need both. Some kids will need both medications to sort of what I think of as, and this is how I explain it to families, sort of bring up the bottom. You know, there's no reserve left, so we need to give them a little bit of reserve in their tank to be able to do the work that we're going to ask them to do in the therapy setting, to take them from being maybe in a more severe state to a mild to moderate state so that they can do the therapeutic kind of work. But cutting and other self-harm behaviors really have different kinds of targeted interventions that people should be aware of.
Thank you. I appreciate that. It's just that a lot of times the family, the parents actually feel very guilty of what happened. And there's also the question among parents that who's the leader that precipitated the events, you know?
Yeah.
And there's always sort of blaming on each other.
Yeah, I think that's whether it's bullying or other kinds of group activities, I think the family, sometimes we don't know, and it just took one comment to set off this horrible chain reaction, and now all of the kids are vulnerable. And I think I try to reframe it with families that are in that stance of trying to get the one who did it, who started to punish. It's like, they could spend their time there, but why don't we spend our time trying to get their youngster well? Yeah. And at the end of the day, isn't it sad that that other youngster turned to this too? And to find some empathy for maybe if we can help our child, maybe that our child can be a leader to help other people and to stop that chain. So just trying to acknowledge how painful it is to have a youngster, to discover that your youngster is doing something that so many parents find so bizarre and inexcusable and upsetting and unacceptable. And I think just, it's just a marker of distress. And I try to reframe it that way. Now, some people are doing something that really is dangerous, and we have to sort of remove sharps and other kinds of things. But I think reframing it as a message, and parents' job, even if they didn't get the message before, they got it now. What do they want to do with that message, and where do they want their energy to be focused? As easy as it feels to blame somebody else, that doesn't actually, even if you identify that leader and get that person removed from their world, it does not fix the behavior that their child has now engaged in. So it's not really a solution to the problem. And I just try to sit with them and say, I wish it would fix it, but it won't.
Not to take away any other questions that may come, but I spoke to a specialist after that, and the psychiatrist actually said, I think it's probably best not to have primary care take care of people who have repetitive problems like that. Yet the patient doesn't want to go to a psychiatrist.
Right.
So how do we deal with that?
I think it's you guys are in a very tough spot, and depending on where you are in the country, you may have easy resources and you may not. So it's all well and good to say, well, you shouldn't take care of it, but if there's nobody else to take care of it, well, that's kind of tricky. That's like saying, well, I don't take care of that kind of cardiac illness because I'm not a specialist, but if there isn't a specialist, you can't just say, well, sorry, not my table. I don't wait on that table. Right? So I think that's a tricky thing. I think that you can at least provide, even if you're not going to obviously do the dialectical behavior therapy, I think there's always a role for a PCP to do education and psychoed, and help families find a way to think about their options. To me, that's always within a PCP's realm, even if you're not going to be the primary treater. And I say that as a child psychiatrist. I'm not a PCP. But I think we sometimes forget the power of conversation and information and education that just the longitudinal relationship that you all have with your patients can offer.